Excited about this portion of the meeting. Since 2021, this now seems so long ago, since 2021, because of the renewed focus on the public health workforce, we've included in Council on Linkages meetings a segment on rebuilding the public health workforce. It's really been quite important. And of course, the academic and practice perspective here and expertise helps us address this. Today, we're particularly delighted to have with us representatives from two health departments who provide us with examples of how the work of the Council on Linkages is contributing to their workforce development efforts. First, we'll hear from Brenna Davidson, who is the Operational Excellence Leader and Chief of the Office of Performance Management for Missouri's Department of Health and Senior Services. Brenna leads the agency's Lean Six Sigma Strategic Planning and Information Technology Advisory Committee teams, which, while working on to maintain Missouri's public health accreditation through the FAB accreditation process. Brenna has a passion for continuous improvement and change management, which she uses to collaborate with team members across the agency to develop innovative initiatives and improve workforce culture. So she'll talk about the Missouri experience. Following her, we'll then hear from two of our colleagues from the City of Milwaukee Health Department. We'll hear from Kiki Lezama, who is the Director of Public Health Workforce Infrastructure at the Health Department and works on building the public health workforce of the future focused on health equity and racial justice. Kiki is passionate about systems change, focused on dismantling systems that perpetuate health and racial inequities from the organization to the community level. She's dedicated to elevating voices of the community and creating inclusive environments for all. Further supporting this passion, Kiki began her doctoral studies, so working full-time and pursuing her doctorate. That is a commitment, pursuing her doctoral studies of public health in leadership, advocacy, and equity at Tulane University. And also from the City of Milwaukee, we'll hear from Lindsay O'Connor, who is the HR administrator for the health department. And Lindsay has 22 years of experience in human resources in a variety of industries, including the past 2 years in public health. Through Lindsay's work, she has written organizational policies from a racial equity lens and changed the organizational culture from punitive to one of understanding and inclusion, meeting people where they are, something incredibly important for all of us today in all of our organizations. So without anything else that I say, let me turn it over to Brenna because you really want to hear from our presenters. Brenna?
Thank you, Ron. If we can go to the next slide, I've got a couple slides for you. So I am Brenna Davidson. I'm the Operational Excellence or OpEx leader here at the Missouri Department of Health and Senior Services. As my bio says, our Office of Performance Management houses our accreditation team. So that is where I overlap with the workforce development world. I do moonlight in workforce development and organizational health initiatives. So just like to say that I'm very excited to hear that you guys are starting a new learning community. And I think some folks here in Missouri will be definitely joining and listening in on those conversations. So if we can head to the next slide, I'm going to pull it up on my other screen too, so I can keep myself on track here. I'm going to tell you all a little bit about our approach to workforce development planning. We were on a very, very short timeline to finish our FAD reaccreditation application just this past year. And we reached out through ASTO. We're big fans of ASTO, and they've helped us a lot in the past for assistance. And they said, hey, the foundation is really the place to go. And so we reached out to Ron and his team and realized that timing and contracting processes and funding was going to be a constraint for this project. So luckily, exciting to know that the FIG or Public Health Infrastructure Grant technical assistance available through the FIVE system actually supported our connection to working with Public Health Foundation. So we're eternally grateful to our CDC partners for that opportunity. So we were able to work with the best of the best to have a plan that is really much stronger than it ever could have been without the help. So part of that process is that we adopted your council link on Linkages Core Competencies as a framework to organize our workforce. So we incorporated the core competencies in the past, but not in the way that we have since. So we started with some job categories you see there on the right side of your screen. We had some meetings with leadership to determine these job categories, because it's not so easy to fit 1,900 FTEs into 6 perfect little boxes. So we really debated on what these should be and what they could be too. We are not considered a super agency, but we do have senior services within our purview, as well as cannabis regulation, state health, public health laboratory. That's pretty standard, but we do have some regulatory entities that are a little beyond the regular public health scope. So we made sure that these categories included folks that do customer support and human services, as well as our classic public health work. On the next slide, we're going to talk through a little bit of the approach that we followed. So this is actually the graphic I used to communicate to team members about what we were undertaking. So under the guidance of the foundation and the FAB requirements, we broke it up into very simplified phases here. We created those job categories in the first phase through leadership, and then sent out invitations through our senior staff folks to say, hey, we need at least 3 people per division. We have 6 divisions and a director's office to attend these interactive workshops in phase 2. And so those would be, okay, we need 3 data scientists from this division and 3 from this division to get the workshop attendees list. And then the PHF folks that we partnered with, that I'm going to call out on our last slide through appreciative work with them, they actually did the facilitation of those workshops. That taking that off of our plate was such a blessing for us, because they really were able to explain the core competencies in a very accessible way, that this is new information for our team members. They did not realize what this framework was or what they were getting into, basically. So we did some education around what the core competencies are and the process itself. Those workshops, they said, okay, everyone in this room, virtual room, is a data scientist. So which of the core competencies are most important to this role? And they picked, there's a perfect setup that the foundation has to rank them. And so we use those workshops to have the definitive ranking of representatives from each category, said that these are the priority competencies. We took those competencies and we created an all staff survey, and that went out, and the timing was not great. It went at the same time as our statewide organizational health survey, but we still got a really great response rate. And I'll go into some details in a second about why we had a good response rate, but every team member had the ability to weigh in on how they felt their proficiency levels were for each of those priority competencies. So they said, okay, I work in data services. I'm going to click that drop down. And then here are the 8 things that we said were most important. Out of 10, how do I feel like I am capable of that? It really is a competency assessment, but we use the word proficiency to kind of, take the risk of getting folks lost in the what's a core competency and then what am I rating here. So we called it proficiency instead. And then we took that information, analyzed it, and the core team behind the scene, writing the plans, actually used it to build the gap analysis to create the training plan to ensure that all the collaborative development was included in the development of the plan. On the next slide, we talk about the communication of things. So I am a communication person by heart, and I'm realizing through our reaccreditation process that if you don't bring people along with you, they don't buy into the plans. And something I learned from our peers in Indiana was a little saying called not about us without us. And so I love the way that they say that, because it's just a perfect encapsulation of the collaborative planning process. So that survey, we promoted it here on your screen. You can see, like, share your perspective to help us create a training plan that works for you, to get that buy-in, because everybody is hungry for training. They want in-person opportunities again after the pandemic, but this was their chance to actually weigh in on what they want to learn and how they want to learn it. So we created an intranet site to house all that information of why are we doing this? How are we doing this? What are the categories and the descriptions, and what do they actually mean? Linked to that survey. And then we had people within our team available to answer any questions that folks had. And then ongoing communication wise, we talked about this. We have monthly department-wide town halls where about 600 to 700 folks attend each month. I spoke about, or we had senior leadership spoke about this project approach, and then we updated them once the plan was complete. We're also planning in April to have a health planning training for our senior leaders where Ashlyn Sherman, who's on the line, who is our health planning coordinator, she and I are going to go through what are all these plans, what's the purpose, how do we want you to use them as senior leaders and trickle them down to your teams so they don't sit on a shelf for the next 5 years until we do it again for reaccreditation. We're really living the plans, not just planning the plans. And then I also speak at new team member orientation about all of these plans. So the repetition, the key to understanding, it's always in front of them and folks are still hearing about these things. So on the next slide, just a quick overview of our work plan, what came out of all of this work. So we have 3 main priorities in our workforce development plan: strengthen the workforce through empowerment, education, and development. That's all about recruitment, leadership development, and training opportunities. We've got ensure a competent public health workforce. That's where those competencies come back in. So increasing the skills around them and training on foundational public health services and health equity. And then our last one is position our agency, Department of Health and Senior Services, as a destination employer. So we want to be that agency that we were like, ooh, there's an opening at health, let's go check it out. So that's recruitment strategies, instilling that sense of belonging, consistent onboarding experiences, and enhanced role clarity for our team members. So the plan is a 5-year plan that is developed in the cadence of our reaccreditation cycle for FAB. This is an entire priority in our department-wide strategic plan as well. So it is linked with these large plans, and it organizes our workforce initiatives with a more strategic approach. We were kind of a scattershot, shiny object kind of approach. So this way we have a very set way that we're going to go about doing this work. And excitingly, we have the plan is published on the Foundation's website as an example of a plan that has built the core competencies into the planning. And so I can drop that in the chat because I'm very proud to have a superlative plan. And then my last slide is just acknowledging the work and the help that the foundation gave us along the way. So Sonia Armbruster there, you see she was the one that facilitated those workshops and really helped us educate our team members on what the core competencies are and why they're important. And then Amanda McCarty was our plan writing queen guru. So we did a lot of, she guided us into like what a plan needs to have to meet those FAB requirements and gave us examples of good plans. We did a lot of collaborative development. So we're eternally grateful, and I'm just really glad to be here today to share the good news that this thing is doable and there are excellent partners out there here to help. So thank you guys for having me.
Brenna, thank you so much for making this real. Really appreciate that. And then what we'll do, we'll take questions following the second presentation. And I'm going to turn it over in a moment to Kiki and Lindsay, who are going to be talking about something a little bit similar, but something a little bit different. In that in Milwaukee, they use both the core competencies as well as the racial justice competencies. So let me turn it over to you now, Kiki. I think, Kiki, you were starting it.
Yeah. So hi, everyone. My name is Kiki Lazama, Director of Public Health Workforce Infrastructure at the City of Milwaukee. So Lindsay O'Connor, who is our HR administrator, is also on the call with us today. And we are going to tell you a little bit about our new workforce initiative that we started as part of our core competency prioritization process. So it's kind of evolved to be this greater umbrella that houses all things workforce, including the core competency process. So workforce is an acronym. It stands for Public Health, Occupational Readiness, Centered in Equity. Lindsay, anything else before we go forward?
No, you've got it.
All right, next slide, please.
So why are we here? This work that we're doing is emerging from the FIG grant that we also were recipients of, lucky to receive. And we're really working towards a public health 3.0 framework. And so in the work that we're doing through this process and the work that Kiki is leading as our workforce development director, really will be partnering with the community, building a workforce representative of the community we serve, finding innovative paths to community engagement, and actively promoting sustainability through the effort so it can continue into the future. Next slide, please. So a little bit of history of how we got to the anti-racism framework and focus. In 2019, the city of Milwaukee was one of the first health departments to declare racism a public health crisis. And the commissioner at the time also worked with leadership to implement our Birth Outcomes Made Better program, which is our doula program, which is showing some amazing results for Black mothers and births in the city of Milwaukee. The city of Milwaukee and the health department joined the Government Alliance for Race and Equity as well, to start learning about how to become an anti-racist organization and mechanisms that government agencies could utilize to become anti-racist. And then we also added a public health strategist focused on health equity in that time frame, so that we could really be intentional about the work that we were starting to do in anti-racism. In 2021, our Commissioner Kirsten Johnson joined us in the middle of the pandemic, fun time, and also brought with her our Deputy Commissioner Bailey Murph, who is the Deputy Commissioner over the Policy Innovation and Equity branch of the organization, and has been extremely instrumental in really centering anti-racism in all of the work that we do. So they started the strategic planning process, and it has 6 goals. And the first goal is to build anti-racism competencies. So not only are we declaring public health racism as a public health crisis, we're then trying to be intentional, centering all of our work around an anti-racist framework. Under Bailey's direction, they did strategic planning. Like I said, there were goals, and the number 1 goal is building the anti-racism competencies. We have done work over 2022 and 2023 in which we've started doing work for our racial equity initiative. We started what we call carrying conversations with our employees so that we can start introducing the ideas and raising awareness of the different experiences that people may have. And also we have implemented an anti-racism policy. And so that's something that the HR team is responsible for managing and ensuring that when situations are occurring in the workplace, we're addressing those things timely and also appropriately, and reporting back to our employee populations on situations that were occurring that are in the anti-racist lens. And then in 2023, we started working on the core competency prioritization along with Sonia as well, who has been amazing. And because of our CDC grant, we were able to put in the 5 requests so that we could partner with PHF, which has been wonderful. Next slide. So similar to what Brenna did, we categorized the 6 job categories. They're listed here. So some are similar and some are slightly different than Brenna's based on our organizational structure. We went through a similar process that Brenna went through. And because of our intentionality centered around anti-racism, we were really wondering, should there be other competencies that we take into consideration besides the competency of health equity? Like, is this enough for us with the work that we're doing centered around anti-racism? So the next slide, I'm going to hand over to Kiki to talk about.
Yeah, so in this debate, when we were going through the core competency prioritization process with Sonia, just like Lindsay said, right, we knew that integrating the core competencies would be using the original 8 domains. But then we looked at racial justice competencies and said, that seems to align with our anti-racist lens, framework, and direction that we want to go as an organization. So, next slide, please. That we then got into the debate of, are there 8 or are there 9 domains? And we, you know, it was, I think, a really great, needed, and timely discussion about, you know, is the health equity domain explicit enough to be anti-racist? And we realized that some organizations aren't ready to have a 9th domain, right? And we'll talk a little bit about how to maybe move towards that for some recommendations that we have. But we realized that not everyone's there. And so there is no real kind of like answer of, should there be 8, should there be 9? But for us as an anti-racist organization, right, moving towards being an anti-racist organization, we said health equity is not explicit enough. We have to use the racial justice competencies as a 9th domain. So, right, we just said that this is going to be instrumental in providing that meaningful anti-racist training and development for staff in having that diverse and representative workforce. Next slide. So recommendations, right? Again, we know not everybody's in that space to have that conversation about, is there a 9th domain? I know some organizations can't even talk about racial equity, but I think that the best way to start is having that buy-in from leadership. We are very lucky to have such supportive administration here at the city of Milwaukee. One of our deputy commissioners, as Lindsay mentioned, Bailey Murph, has been instrumental and has really led a charge in this anti-racism work. And a lot of this probably would not be possible without her leadership. So, right, you're going to have those strong players and sponsors to push it forward, especially I know that there are a lot of polarized communities, especially resulting from the pandemic. But one of the things that we focus on, especially for staff, is talking about, right, universal benefit. You always want to use positive, right, connotations if you can, but it's right the opposite of saying, right, to avoid universal harm that racism causes, right? So to help leadership in whoever is in those decision-making positions to say, hey, actually, yes, I know that this is, right, maybe a polarizing topic, but here's how racism hurts our entire community, right? Not just communities of color. And so communication with staff then around that is going to be extremely important, right? What's expected of staff, how to support, right? How our work supports anti-racism, right? And how we promote more equitable outcomes, right? And begin those introductory trainings on frameworks, shared language, values, and really with that, right, the kind of nuance of like creating a culture around that. Making a public declaration is also very helpful, right? It creates accountability. And it's also then a great platform to educate the community about universal harm, right? Or universal benefit, depending on how you want to talk about it. Because it's, right, this is something that we want obviously staff to be aware of that. But in order to sometimes get that buy-in, especially from government, right, you have to know that, hey, this is the approach we're going to go, and this is the narrative that we're going to create around us, rather than having a narrative created around, like, surrounding us, right? Like, we're going to be in the driver's seat of that narrative. I think I was saying everything on that one. Okay, next slide, I think. Anti-racism policies. So a really good thing is to have very explicit outlines and standards of what is expected from staff and what will happen when racism is encountered in the workplace. Also, things starting from even before staff is hired, anti-racism questions and interviews. So these are now included in employment interviews and also in placement interviews. We do not have a student-specific placement program. Our placements also include volunteers and shadows. It's to create a wider net of exposing people to public health. But also when they apply for those placements, they are asked about how they will contribute to the anti-racist direction of the organization. So we're starting from the very beginning. And ongoing communication. This is kind of a build on what we mentioned in the previous slide. Right, we want this ongoing communication. That could be social media, that could be in what's being discussed in narrative and shared language, in who's going out into the community, right, around anti-racism, and to promote community around it, saying, right, if one of us is not healthy, then none of us are as healthy as we could be. So that's a little line from the Minnesota Department of Health that I always pull, but that's really the essential right of what it is that we could try to implement all of the trainings and all of the great programs, but if we continue to ignore something as huge and pervasive as racism, we won't achieve health equity. Lindsay, anything else that I missed on that? No? All right. I think that's it. And then if you write questions, obviously, I know we planned on going second, so that's why I added that slide. But then, yeah.
Great, thank you so much, Kiki and Lindsay. And Kiki, I'll also mention that there's a short video that you all developed for your staff on the process that we also have housed on the Public Health Foundation website as an example of how a health department is using the competencies. So thank you for that. While you're thinking about questions that you have and the discussion you'd like to have, as well as other examples you may wish to share with us, just want to emphasize what we just heard. Two different health departments, one state, one local, where they're using this tool that the Council on Linkages created and periodically updates to help the workforce within the organization continue to advance, improve, and actually even serves as a motivator, is what I heard in some of the conversation here as well. And of particular note is I think we really are moving in our field from maybe years ago where agencies maybe used the core competencies as a step, but didn't quite know what to do with them after taking an initial step. The examples we just heard about are how we're using them, how we're going to continue using them, how we're moving forward with implementing our workforce development plans, and also, given the people involved here, we're also talking about continuous improvement of those plans, which is all quite exciting. So now that I've given you all plenty of time to think about questions and the discussion, let me open it up to everybody else who's on the call. Anita.
Good afternoon. My name is Anita Balan. Quickly, I represent the American College of Preventive Medicine. I'm the Director of Residency Engagement and Development at the American College of Preventive Medicine. We are in the process of identifying a representative for this very important group. So we're hoping to have a PrevMed physician from the next meeting. Excellent presentation. Thank you very much. My quick question is, preventive medicine is a recognized specialty, and it's a specialty that's trained, where physicians are trained to work in clinical space and public health, and many of our physicians lead state and local health departments. So my question for both departments and both presenters is, as you are looking to optimize your workforce development, as you're looking to improve your processes, what is your feedback on, if you want somebody who is not recognized as part of somebody who is not trained based on the core competencies of public health, but if you want us to introduce PrevMed physicians or other workforce that is critical that's critical for the state and local health departments to carry out, what are your recommendations on how we can approach you and say, hey, this is another workforce, this is another segment of the workforce we want you to keep in mind, who are trained in these skills as well, in addition to or in correlation to or similar to the public health core competencies that we would like you to consider to fill the gaps, the incredible shortage and gaps that are taking place across the country. So what are your thoughts and approaches on that as you implement these work plans and workforce development plans moving forward?
Milwaukee friends, did you want to go first, or I can jump in if you're ready?
Go ahead.
Okay. So I love hearing that we are building that connection between the medical community and the public health community, because it's a system-wide thing. So here in Missouri, we recently, well, not recently, I guess she's been here about a year. We brought on our first chief medical officer, Dr. Heidi Miller. She's excellent. She's very preventative minded. And she's just a great energy, and she's done such a good job jumping into the public health world and understanding how we operate and how we can bridge the gap between these industries. So just want to plug that link in the chat to the Missouri plan. There's an appendix at the end. We have, I believe it's about 2 years old now, we have a workforce council that is public health and healthcare in the state of Missouri. It is something that came through a kind of grassroots initiative. We all knew that the public health and healthcare workforce was decimated during the pandemic, and we need to get innovative new ideas to create those pipeline programs and things. So the council is supported by our governor's office, but co-chaired by our department and our state Department of Higher Education and Workforce Development. That council has kind of formalized what we are working on. And so an appendix in our plan includes a progress report for 1 year of activities around 24 priorities in that council is pursuing. And they are innovative, big ideas from starting at middle school age to recruit and build that public health workforce, but also connect our associations, our primary care association, hospital, all those folks that we work with all the time with new approaches, because traditional methods aren't going to get us there anymore in this workforce world. So just wanted to plug that. But I also love the idea of building that gap between preventative health medicine and how public health is prevention. So excited to see you here and on the council as well.
Lindsay or Kiki, anything you want to add?
I think so. I'm sorry, Anita, could you just make sure, I want to make sure I understand your question. Could you say it one more time?
Yeah, so preventive medicine physicians kind of are trained to, they go through residency training after medical school, and they're the only specialty they're trained to, get public health training as well. And they have a different set of competencies, not the public health, core competencies, and very similar, but not exactly the same. So I just wanted to kind of plug in selfishly, preventive medicine physicians who work in that bridge between clinical care and public health, healthcare and public health. And so how do we, as those of us, the workforce segments, such as preventive medicine physicians, and perhaps other workforce segments, public health workforce segments as well, that you may not have come across yet, how do we ensure that you are recognizing that these additional workforce segments that also exist, like preventive medicine physicians, that can help to fill some of the gaps that the state and local health departments are experiencing, to address health equity, and to explicitly help you be anti-racist and help you fulfill the competencies that you've established as a framework. So how do we engage with you proactively and bring in these workforce segments that may not have been in the front of your mind is my question, if that helps.
Yes, no, it does. I just wanted to make sure I didn't give you a hollow answer. So I think this kind of brings back to what Lindsay and I discussed about Public Health 3.0. And so as we go into Public Health 3.0 and saying, okay, what is the role of public health? It's moving away from direct services and into systems work. In the event that that work is duplicated by somebody else in the community, we're saying, okay, if someone else is doing it, we trust you. We're going to be that convener. We're going to be that facilitator. We're going to be that gap provider, right? We're only going to provide that service if there's a gap. So I think in that whole transition, when departments are going through that, they should be reaching out to, right, these different organizations, right? We're not just talking about nonprofits. We're talking about the whole medical system, because we're then relying essentially on how equitable it is or not, right? We're relying on you all to be providers. So that collaboration is already going to be heightened, right? As these organizations transition into 3.0. So those conversations should already be starting to happen. I know everybody's on a different page when it comes to 3.0. But that's essentially how that relationship is being depicted, right, by that Public Health 3.0 framework. Is like, yeah, we have to work together because we're not going to duplicate services. We're not going to step on your toes. We understand that you have a scope in being able to provide, right, direct medical care and address, right, pathology, right, and we can be more on this end, right, in like maybe policies, systems level work, but the talking and the collaborating is going to be that much better because there's a lot of things that government cannot have their hands in necessarily, right? And so I think a lot of that systems work as the convener or the collaborator or the facilitator is going to be elevating these other community partners in order for them to do that work because they have that ability to do that. So it's more like we're the weaving the web, right? And I think one of the challenges though that comes out of that is because now even as we move into 3.0, it's another shift in how people understand public health to work. People already don't know what we do, right? They're just like, so what do you do? Like, do you work at a health department? So you give shots, right? Like they still don't understand, right? And so it's going to be that much more important for those relationships to be ongoing. Regardless of where people are at in the process, just constantly, if you have partnerships or coalitions, just constantly talking because you never know, especially because everybody is at different levels in the 3.0 transition, you never know where that collaborative, like reciprocating benefit, right, can happen, or like, when do you need to come in versus I come in? It's going to be a lot of recalibrating just because we don't really have a great manual on how to implement that, right? Or how to change that relationship dynamic, right? We're all kind of going from, all right, we have this basic framework and here's how we think it works for our communities. So I don't know if that helps. That's okay. Wonderful. Wonderful.
Great. Other questions and comments and examples? I know there must be some out there. I didn't see a hand up. I'm sorry. Is it Medha?
Yes, Ron, that was correct. It's Meda. It was more like a comment, and I did see others adding. I think Erica has added what her public health is doing with some of the residents from the local university. I come from New Jersey, and something that we are trying to do is, or we have been doing, is allow for the rotations for the residents from our regional universities, especially residents coming from preventative medicine, programs, to come and experience the public health department and the work that we do. And I believe that I'm a primary care physician by training myself. I do see a great value in understanding our boundaries, but do boundary spanning work. It's like we come with our sets of competencies, and to really get experientially involved in these types of different projects, cross-pollinated projects are helpful. I see that is one space of learning the competencies, bringing your sets of competencies, and see where we have synergies and where we have ability to bridge the gaps. And so that's one exploration. In fact, that's one of the projects I was going to offer to one of our future residents who was coming on board. And I was going to embrace her in our CHW work that we're doing, because that is a new space that we are building, the community health worker workforce. The more that they are, they are aware of the other types of workforce also working out in the public health, they are going to better utilize it as they practice medicine, whether it's in an acute or care setting or in the community, clinics or elsewhere. So those are some ways I see as looking at it as boundary spanning work, embracing others' competency, but also keeping your specialty competencies that you bring from your, training and education.
Great. Thank you so much for sharing. Other questions and comments? One thing I will mention before we move on is that certainly we have two larger health departments here. Missouri, I think, Brenna, you said 1,900 employees. Kiki and Lindsay, I don't recall the number of employees, but you're fairly large. Or Lindsay, do you, at the top of your head, do you have a number?
Currently, we have 230 employees. At full strength, we would have 340.
Wow. Wow. So you'll be doing a little bit of recruitment. So 2 larger health departments, but this process of prioritizing the competencies and building them into workforce development plans and acting upon them, we've seen it being used in health departments from, oh gosh, the size has probably been around 25 people, to several thousand. So it's something that is, I think, useful to all of the various organizations, regardless of the size. The process is fairly similar. You can imagine, though, grouping into 6 groups or so in a health department of 25 could be simpler, but then sometimes more difficult, because you think of all the multiple hats people wear in a health department the size of 25 as well. I see it looks like there are a couple of items in the chat. Okay, there were comments. Any other comments or questions? Well, Bill, it looks like it's time for us to move back to you.
Yes, thank you very much, Ron.